Hey, John, how you doing, sir? Good. Madam Clerk? I call the Charlottesville City Council September the 15th, 2025 meeting to order. Madam Clerk, will you please call the roll?
Councilor Oshrin,
Present.
Councilor Payne,
Here.
Vice Mayor Pinkston,
Here.
Councilor Snook,
Here.
Mayor Wade.
Here. Thank you. Is there a motion to approve or amend the agenda?
So moved. Second.
Okay, are we voting,
Do a voice vote for now.
okay? All in favor, please say yes.
Yes.
All opposed, please say no. Great, great. So, the meeting will be divided into, three sections. The first one will be, a work session where we will hear and discuss, presentations that do not require a council vote. And then we will go into closed session. Then the city council will have its regular business meeting at 6:30. And today, we have three reports, one from the Charlottesville Free Clinic, the Blue Ridge Health District, and the Child Health Partnership. So the first we have is the Charlottesville Free Clinic.
I guess I speak here.
Yes, yes. And if you need a clicker, if it's not there, then it's at the other one.
Hi, my name is Willa Barnhart. I'm the Executive Director of the Charlottesville Free Clinic. And thank you for inviting me and the Free Clinic here today. So, as you know, the Free Clinic is a nonprofit healthcare organization. We serve the working uninsured and underinsured members of our community. And our primary objective, we went through strategic planning a few years ago, and what came out of that was that we wanted to see more patients and provide more integrated care between our medical and dental clinics. And I believe we've succeeded in hitting those goals, and we're going to continue to do so in the coming years. But to that end, what we've done is in the last year, we've built a new dental clinic, and that's been a huge success. There are now 6 clinic rooms as opposed to 4, so we're filling those with many patients in the community. We've modified our dental clinic eligibility to ensure that patients between our medical clinic and dental clinic can access that care easier. And we're working on expanding our specialty clinics to see more patients in the medical clinic. We also do something called easy access in our medical clinic, and that means that anyone that needs, is in need, they can come to they can call, make an appointment, walk in, and we'll try and see them as soon as possible. And then we'll assess what they need. They get one appointment, and they get a 30-day prescription, and then we help them navigate the healthcare system to see if we're their appropriate home, or perhaps they need Medicaid or Medicare, and they can go somewhere else. But to take a step back, the whole reason we do this, and we kind of look at the community at large to find out, where's the need, and we look at the census data, and those numbers are for Charlottesville and Albemarle, and I'm sure you're all very aware of this, but close to 11,000 people without health insurance, 19,000 living in poverty. And then we also often look at the United Way, the asset limited income constrained employed. That's kind of our demographic. And there are close to 19,000 households in Charlottesville and Albemarle that live within that category. And so our whole mission is to serve these people and make sure they know about us. Overall, in the last year, we provided just over 9,000 visits between our medical clinic and dental clinic. And then our patients were pretty split between our dental and medical. And there was a 10% increase there, which is great. And that's what we're always striving to do, is reach more people, see more people across the clinics. We do this with a small staff. Our medical clinic has only one staff provider. She's a family nurse practitioner. And our dental clinic, we have one dentist. We struggle like any other small organization with staff turnover, but we try to do our best to keep quality quality employees that really care about our mission and serving the community. We also rely on many volunteers in the community. So we had 972 volunteer roles that were filled by 754 people last year. Just the number of people in and out helping our community through the free clinic is incredible. Of these, they were doctors, dentists, nurses, people that worked at the front desk, helped fill prescriptions. 154 of them were doctors, and they usually come from Centera and UVA after their day jobs to our evening clinics and see our patients. So then just to highlight our medical clinic, we've made every effort to do more and see more. To that end, we started offering physical therapy. That was a service that we used to refer out to ACAC, and patients had to pay a stipend to go and get that care. Now they can come to the free clinic and they get it for free. This is really good because if anyone's been to physical therapy, you often need to go more than once, and that can really add up. So we have 2 volunteers now, and we're looking at adding a 3rd, which is just a wonderful addition. We also have seen a big need for optometry, and that's something we added in the last 2 to 3 years. We have a room dedicated to optometry where all the equipment was donated, and a couple comes every month and donates their time. And we work with partners to provide glasses to our patients at a discounted rate. Another thing that I want to highlight with the medical clinic is our mental health support. So we had about 840 mental health visits last year. Those are offered through our family nurse practitioner, who's also a counselor. We work with the Women's Health Initiative, and we have a volunteer that comes in every Thursday to see patients. We also offer PHQ-9s to every person that comes in for their first appointment. They fill out a PHQ-9 to evaluate if they should be offered a connection with a mental health resource, and we do that every 6 months just to check in with the patients.
What's a PHQ-9?
A patient health questionnaire, so it's 9 questions to evaluate how your mental health is.
Got it. Thank you.
And are you having problems finding mental health workers or volunteers?
We always want more volunteers. So, I mean, yes, but we are okay. Because we do also pay the Women's Health Initiative, we have that support of the reliability of a paid staff member.
Okay.
And we're lucky enough to have this one volunteer that comes every Thursday. But if we had more volunteers, would we be able to fill those appointments? Yes.
Okay, thank you.
And then another piece of the medical clinic is that we do a lot of, like I said, specialty services. But if there's something we can't provide in the clinic, we refer them to outside clinics or outside partners. And we pay for those visits. The patient pays nothing. So VA Breast Care, Charlottesville Radiology, or Gastro Health, they'll go to those appointments and they pay nothing. In our budget, it's about between $60,000 to $80,000 a year, so it's a significant cost, even though we're paying a discounted rate. But it's very important if somebody thinks that they might have cancer or something else more serious. So that's our medical clinic. This is a snapshot, and I think it's pretty neat to see. We do 3 evening clinics a week, and they involve a lot of people. So there's usually about 3 staff, a significant number of volunteers. We have between 12 to 35 patients. Our pharmacy is also open at the same time. And then usually we have a restaurant donate dinner to the volunteers. So that's pretty nice. Our dental clinic, in the last year, I mentioned that we have a new dental clinic, which is really exciting and it's helped recruit volunteers. I think it's given the patients, I guess, a renewed sense of excitement to go to the dentist. And it's also helped, we hired a new hygienist. So, as I'm sure you've heard, The hygiene, finding a hygienist is very hard. We were able to find one through a VCU rotation. She saw our mission. She said she had been at the free clinic when she was younger, and she really just wanted to get back into that kind of mission-driven work. So we hired her in June, and that also helps us increase our patient numbers and patient visits significantly. We were hoping we would have hired her a year ago, but that's just kind of how long it takes in the market today. We also, though, at the dental clinic, in regards to staffing, rely on VCU. VCU, we have 4 VCU dental students come each week and 2 VCU dental hygiene students come each week. And this just supplements how many patients we can see. We have a small number of dentists volunteer, but much smaller than what we see in the medical clinic volunteers. What else about our dentists? Oh yeah, my gosh, this picture says it all. So digital dentistry is a brand new area that we're exploring. We were gifted a 3D printer. So when we used to people would come in, they're in pain, they have nowhere else to go, they come into our walk-in clinic, we generally evaluate them, probably pull a tooth, and then we try to set them up for hygiene and comprehensive care. Now we could actually replace that tooth, which is really significant. Imagine trying to get a job if you're missing your 2 front teeth. And so since June, we've provided about 75 occlusal guards, which are night guards. We have done 14 removable partial dentures. That means if someone's missing one of their front teeth, we're providing a new tooth for them. And we did our first crown today. We've partnered with a third party called Dandy, which is a digital dentistry company, and we're getting reduced rates because we're a free clinic. So that's, I'd say, the biggest advancement our dental clinic has seen in a long time, and it's been great for the patients. We're just kind of balancing the cost of this service with how much we can do. And then our pharmacy. Our pharmacy services our medical clinic and some of our dental clinic patients. We are able to provide an incredible value of pharmaceuticals at a much reduced cost, in part because of a prescription assistance program. And that means that once we get income eligibility from a patient, we work with the pharmaceutical company to get that medicine at a discounted rate. And it's been an incredible way that we can provide medicines to our patients. We also recently switched software, which made it a lot easier for our volunteers to help in the pharmacy. And just, this shows you, but generally, we save about $100,000 to $160,000 every month through the PAP program. And then, we don't need to get into this, I feel like you know this, but just looking forward, we're bracing for our patient numbers to really increase. Medicaid, not as much because, Medicaid will impact us, but we don't see patients with Medicaid. But ACA, with deductibles going up and people not being able to afford their health insurance, that will significantly probably grow our patient base starting in January. We're not making any internal changes. We're going to see what happens and then decide what we need to do. But that's kind of what we're bracing for. Those are all the slides I had and the highlights from the last year. But I'm happy to answer any questions.
Yeah, Michael, do you have any questions?
Sure. Obviously, you've touched on ACA, Medicaid changes. Do you have a known scale, if any, of how much budget impacts you're expecting over the next several years in terms of the budget available to you from changes in federal funding?
Well, we don't receive federal funding, but there could be downstream consequences for that. So we are incredibly grateful for the City of Charlottesville support. That's makes up a significant amount of our budget in Albemarle County. We receive money from the VAFCC, which is the Virginia Association of Free and Charitable Clinics. But but that's state funding. What we have seen in recent like donor conversations is with all the unknowns going on, people are just giving less. And I've noticed that over the last 3 months. More than 60% of our funding comes from individuals, so that's a little worrisome. But unsure how the federal funding will impact us because we don't directly receive any.
So I guess at that point, your biggest anticipated impact is just a likely rise in demand, less so something from the federal government or pass through from the federal government to the state, impact.
Yeah, the VAFCC goes to the General Assembly every year, and we try and talk to the lawmakers and actively work with them to talk about the value we provide. But yeah, it's
Okay,
unknown.
thank you.
Natalie?
I'm curious about what kind of, I mean, a lot of the work you do is very specialized. What kind of qualifications do volunteers need to have? Is there a spot for anyone, or do you have to have some?
So it depends what the position is.
Right.
We're always looking for doctors and dentists because those are people that can actually provide the care. Ideally, if somebody is bilingual, that's even better. But we have on our website, you can apply to become a volunteer. We have community members that don't have medical backgrounds that can volunteer at the front desk or in exit interviews. But otherwise, usually it's made up of either doctors, retired dentists, somebody in the medical or dental field, or a community member that just feels passionate about community health, and they could, like I said, those other positions, or even hand out prescriptions. So there's a place for anybody. Yeah.
Okay, great, thank you.
Brian?
No comments, just thank you for the work that you do and really enjoyed the presentation.
Okay,
Yeah.
thanks.
Ditto.
Yeah. Yeah.
Enjoyed my tour.
Oh, good, yeah.
Yeah. A few years ago, Brian, I think, Brian, you and I took a tour, and it was this amazing operation that you have there, of the different things that you do. It's amazing that all that is done by primarily volunteers, and I just think that I know that our community would just be a lot different if that safety net wasn't there. So thank you all so much for what you do. And I just was at a couple other meetings today, the tourism and JABA, heard some of the same things about well, not the tourism, about the funding and donors, that people may be still giving, but they may be giving less because there's some uncertainty. So I think we're going to be hearing that a lot. So anyway, thank you for your incredible work, and appreciate you coming out. This is like a health presentation evening. So
I know.
the next one will be the Blue Ridge Health District. Brian, are you doing it? Okay.
I appreciate the council's invitation to come present on some highlights that we have, but also to discuss where we are with our federal funding. It seems timely as the Virginia Department of Health, and certainly the Blue Ridge Health District, learns a little bit more about what's coming out from different funding proposals, what we've learned over the last 3 to 4 months regarding a number of our federal grants, and to really say that across the country, public health is at a crossroads. Funding that we've received for decades to support some of our core services has factually been cut or is in limbo in terms of what we're going to receive. A lot of the guidance that we've received, longstanding guidance around how we prevent the spread of disease, how we provide treatment, is either changed, is proposed to be changed. And so while public health always lives in sort of this dynamic situation and working environment, it's much more prevalent, and I think we have a lot more questions than we actually have answers to at this point. And so what I'd like to do today is really take sort of the abstract around those cuts and really make it local. What are the true impacts that we would receive at the local level? The negative impacts, the lack of services, the access to care, that won't only impact the health district, but could impact our partners, if you've already heard from Willa today about the potential for an increase in the clients that they see. And then I'll take some of those highlights from the year and really apply those to the grants that we're looking at that may have some potential cuts moving forward. So just kind of as a reminder and sort of set sort of the mindset around what our thinking is, we serve 6 localities in our district that correlate with PD 10, Charlottesville, Fluvanna, Albemarle, Greene, Louisa, Nelson, and we also have a Yancey Community Center that we have occupied for a number of years. Our services there are pretty much educational with a bit of clinical services. But when we're thinking through our budget, our decision making, it's specific to Charlottesville, but it also incorporates all of the other things that we have to look for. Public health and health does not look at borders, it crosses borders. And so the decisions that we make, the actions we take, the services that we provide do translate into overall health of our district, incorporating that into the health of our state. So we obviously look specifically within each locality, but we also keep in mind that what we decide in one locality may have an impact on the other. Here are our core services. We provide some or all of these in each of our locations, depending on what the need is. Something I want to highlight is that everything that's in yellow has some sort of federal funding in terms of a grant attached to it. Some of it is in whole. So our Public Health Emergency Preparedness Program, the director of our epidemiology program, 100% funded by what's called the Public Health Emergency Preparedness Grant, and has been funded fully for nearly 23 years, since 2002. Others are partly funded, so family planning is a small number. Our TB grant is a small number, but when we start looking at this holistically, those small numbers add up. Our grant funding for the current fiscal year is right around $1.8 million, the bulk of which is with our WIC services program, which is around $738,000, and then our Public Health Emergency Preparedness Grant, which is around $260,000. So you can see the potential impact here, even in small numbers, but our larger numbers, where if we saw significant cuts, that would be a pretty impactful thing for our staffing, but also for, and most importantly, the communities that we serve. I do want to highlight something that I had communicated to Mr. Sanders and other local government officials back in March. Seemingly overnight, we lost about $2.9 million in federal funding for our COVID-related grants. Now, these are grants that we had received, obviously, during the pandemic, and had received no-cost extensions really through June of 2027. And so as we were looking forward, we were tying a lot of our community health worker positions, epidemiology positions to these grants. The immediate impact for our staffing were 15 positions that were lost. Most impactful, though, is what that means for the community, particularly around our community health workers who did offer office hours. And during those office hours, we were connecting individuals to services that might be mammograms at UVA, and might be money for rent or electric bills, connections to our community health network outreach work group, who focuses on connecting people to jobs and other different services. And so the loss of those dollars and the loss of those positions were pretty significant to that program at that time. The long-term impact, I think, still remains to be seen. Obviously, we've offered fewer office hours. We don't have the same capacity to investigate COVID outbreaks within congregate settings, but those are the most vulnerable places, or most vulnerable people to get COVID. And so we've really had to partner with our regional epidemiologists to bring in individuals to address those outbreaks. Some additional funding cuts. So the Ryan White program at the federal level, which is a pass-through grant to the states, is a pretty significant program where individuals receive medical and non-medical case management, access to low or free medications that are truly life-saving, but they're also preventing the spread of other diseases. VDH and many other states have received significant cuts to that. We had also lost some rebate funding from the pharmaceutical companies. And so VDH made a decision to cut funding across the board, not just for local public health. There are 5 health districts who did receive funding for Ryan White, but also to community providers. UVA Health is still receiving funding, still able to provide a lot of the services to the individuals with HIV. But for us, and we were non-medical case management, we've had to reallocate those responsibilities to other people on our clinical staff. On the right-hand side, disease intervention specialists. So when people test positive for HIV, for other STIs, we have an individual who is responsible for doing the contact tracing, making that connection from us at the health district to someone who's going to provide treatment. Sometimes that's us. We have 2 nurse practitioners who can provide some STI treatment and ongoing care, and sometimes we refer them to UVA. We did lose about $5,600 for that position, and it's absorbed that cost into our non-grant, we call it our cooperative budget, non-grant funded budget. And so we are able to maintain that service. While not mandated by the Code of Virginia, this is one of those things that only we can do. This person is the only person in our district, along with our team, that does this type of investigation, that does the outreach, that really brings people in. And so we find this to be a critical component of our response to STIs. Things that we're looking at in the current budget, things that either have come up in Senate proposals, the House proposals. One includes family planning. About $31,000 here is at risk. We use this funding to partially support 2 positions, a public health nurse and then the nurse practitioner who runs that program. Maternal and child health, we received a small cut last year. Some of this is federally related. This is also related to VDH changing their formula. And so we received a small cut there, again, absorbing those costs into our cooperative budget. Other projects and programs we're looking at, TB control, nothing specific, but when you see general comments in funding proposals about reducing funding globally for TB and then in the United States for TB programs, we are planning as if this may occur and sort of putting that into our budget planning, not just for the current fiscal year, but the next couple of fiscal years. And then emergency preparedness. So federal funding could drop by $385 million nationally. And what that means for us is about $260,000 locally. And I'll explain a little bit later about their role and what this means for our communities. So here you can see the positions that are at risk, the programming, the staffing, the services. All of this involves traditional core public health services, from disease investigations, emergency response. So we could think big picture like COVID, or we could think about smaller things. Pertussis outbreaks in elementary and middle schools, outbreaks, not just COVID in long-term care facilities, GI outbreaks, norovirus outbreaks. And so the capacity that we would traditionally have, if we lose those funding dollars, we would be hard-pressed to sort of stretch our resources and make sure we can continue those services. So for fiscal year 25, here are the highlights of the programs that are funded by federal dollars that we're really considering are at risk. So you can see in our clinical services, the number of sexual health clients, family planning clients that we have, the number of TB screenings we do. So a lot of the TB screenings that we do are for our public schools, for teachers. What I learned today is that CVS no longer does the TB screenings, and then another program in the community that does TB screenings no longer does it. So we have to adjust our capacity to be able to expand that, and we will be doing so beginning in October. But as other programs begin to fall off and we have to consider taking on those responsibilities, again, it's sort of another contributing factor as to our return on investment in those TB dollars. You can see the immunization visits. Largely, that's around back-to-school vaccinations to assure that students can start kindergarten, 7th, or their 12th grade years, provided that they have the right immunizations. And I think between EP&R and the EPI and DIS, so these are the STIs and the responses, these are, I think, among many priorities, chief among them for me. Earlier this year, we had 2 responses to public health threats. I wouldn't say that they were epidemics, but the meningococcal disease, it is a rare disease, but it is serious and can be fatal. And we encountered this earlier this year. On the measles response, 2 cases were identified. They were linked to each other, and to the credit of our staff, to our partnerships with UVA Health, the University of Virginia, and VDH, in both these instances, we were able to limit the amount of spread that occurred. In some ways, we didn't actually have any spread. But it is a huge resource lift. We have to close clinics to be able to provide access to the vaccine. The thing about disease, though, is that if measles is happening, so is COVID, so is flu, so is pertussis. And so when we think about all the dollars that go into one position or one program, it touches all of what we do as a health district. And so there's great concern about what our capacity would be to support these responses if further cuts occurred. So our strategic direction, a lot of what we're trying to do is look at our budget and how do we move key positions or portions of our grant-funded positions over to stable funding. So funding that we get from the city of Charlottesville, the state of Virginia, 1 year to the next. We can't eliminate all of that. We have to have some reliance on the federal grants. But how can we minimize that? How can we assure that we're going to have an emergency preparedness coordinator or manager, that lead district epidemiologist, who are all grant funded, to assure that we can respond appropriately and just maintain the day-to-day. So we're looking at strategies internally. As we think about our budget requests, which will be coming in October, we're going to think carefully about what we're asking for and what particular resources we need for the programs that we feel like we absolutely have to have, not just because they're mandated by the Code of Virginia, but because it's the only thing that public health, or the only organization that can perform those tasks. We also want to make sure we're looking at what our partners are doing. So for the city of Charlottesville, this isn't necessarily a question for you, but how are we aligned with your strategic priorities, looking at your comprehensive plan? Health is littered throughout all of that. How zoning is addressed, how buildings are addressed, how we have access to healthy foods, all of the traditional things that public health wants to do too, to be part of that. And so that comes into what we're trying to accomplish with the resources that we have. So one thing I do want to highlight, I did send an email today, and Mayor Wade, you made a comment about Jen Fleischer and Tamika Irving. They are true ambassadors of public health. They are essential to what we're trying to accomplish, not just as a health district, but our partners at Blue Ridge, at Sentara, UVA Health, and then all of the community organizations that are working with us to improve overall health and well-being. And certainly our budget would have an impact on our ability to support the activities, but it wouldn't impact our ability to influence and drive policy changes, supporting our community partners and delivering those services and resources. I won't go into great detail here. Jen has presented this to you. You have the electronic copy in your email boxes. What I would say is, though, the Community Health Improvement Plan is something that we will be working on. This is where we move from action, or from understanding to action. What will we do to implement strategies? What will we measure to determine changes in health outcomes? And how is that going to look like in real activities over the next 3 years? To close, I'll reiterate, we are certainly at a crossroads, but that does not mean we're deterred. We are very determined. Our staff are willing to do what it takes to deliver the services that we need to, regardless of where we are with the funding. I will add, we are closely watching the hopefully approved budgets that come from the federal government by the end of this month, because if not, we'll have to consider what that means if those grant dollars don't come to us, which may mean putting people on furlough. We're working right now to determine how much money we can keep all of those individuals over the course of a month, 2 months, 3 months, where we alter our clinic services or our services in general to make sure we can maintain some basic level for the community. But it remains to be unseen how much shutdown would impact us and for how long. And with that, I'll take any questions you may have.
Thank you. Lloyd, do you have any questions?
I'm just struck, presentation after presentation that we're getting of who knows what's going to come out of Washington. And I appreciate the difficulties that you all have in trying to make sense of things and contingency planning and contingencies upon contingencies. And I have no questions, just sort of respect for what you're doing.
Yeah.
Thank you.
Yeah, excuse me, I would second that. Are you getting, if this is something that's even borderline controversial to talk about, just tell me to stop. Are you getting any sort of policy direction or directives about things that you think are like, this is weird, why would we be doing this? We've been telling people to get their shots forever, but now we're I don't know, are you getting, are you getting any kind of policy as part of the VDH? Do you have, I'm assuming the VDH has a level of autonomy in terms of its policies for vaccines or whatever, separate from whatever the federal government is doing. Is that true?
That is true. Some of that's set by the Code of Virginia.
Okay.
And so back-to-school vaccines,
Okay.
measles, mumps, rubella, those things, those are all in the Code of Virginia. So we have the legal statutes that are there that allow us to promote and require certain vaccines to be put in place for schools. You know, I think the policy around COVID vaccine is a little more fluid.
Okay.
The State Commissioner of Health on Thursday issued a standing order that removes the requirement for a prescription to be written so that a pharmacist can administer COVID vaccine. So someone does not need to go with a prescription to have that done, provided that they have the underlying health conditions for the requirement. If you're 65 and above, you don't have to worry about that. So that was a huge barrier, I think, and that's one where we have that autonomy at the state level. Other states are doing different things. Some it's come one, come all, you can get your vaccine. Here, we're just trying to make sure we're removing that prescription barrier and then addressing things that come up. So the next meeting at the federal level is on Thursday, Friday to vote on COVID vaccine, whether or not it's going to be approved for free vaccine for children, free vaccine for adults, what the requirements are going to be for children to get access to the vaccine. So there's still some uncertainty there. Fortunately, anything that's in the Code of Virginia would require a change in the code.
Okay.
So we feel pretty comfortable with where we are with that right now.
Good. Thank you.
Natalie?
Thanks. Yikes. This is what I kept during your presentation ringing in my head was Ashley saying social determinants of health over and over again at previous presentations, and how all of the things that you promote, provide, educate about are worthwhile and a good thing to have funding for, because it has all of these downstream positive effects in the community. So it's tough to see how in jeopardy everything is for no good reason. How come CVS and the other institutions stopped doing TB tests? Do we know?
That I don't know. There's certainly time as a factor in that. I'm not sure if now having greater ability to provide COVID vaccine has contributed to that, where they have to make a decision. Mm-hmm. I'm not quite sure. But okay. As far as the TB screenings, you know, I think we have the capacity to take that on. The other thing that we do, especially when it comes to schools, veterinarians will set up an agreement where we know that we're going to screen 55 people for that organization, and so we can sort of plan accordingly. So it's an adjustment. It's adding some clinic time, maybe taking away from some other things, but something we feel comfortable taking on at this point.
Okay, great. And then I know the potential for a government shutdown is looming, mm-hmm. and you mentioned how that would be negative for your daily operations. Would that kick in immediately, or is there like some time we can write it out before?
There is some time that we can write it out. I'm not sure I can confidently say how long.
Right.
And the idea behind that would be we would make sure people are paid through our cooperative budget, and then we would sort of reallocate those funds back to the grants once the shutdown occurred. And so we're taking a lot of steps internally to figure out pay period by pay period, what can we afford, and then what can we expect to get back in return from those grants. There could be some pain there, both in terms of our staff, in terms of what we're able to offer the community. So I don't want to downplay that. I think that's still really important. So it's unknown for how long, but we feel like we have a plan in place that would allow us to, for some length of time, continue to offer services.
Okay, thank you very much.
You're welcome.
Yeah, as we heard earlier and you outlined, it's obviously, a perilous moment for public health with premium rises, devastating cuts to Medicaid, SNAP, along with cuts to public health providers, all coming together with more people unable to afford preventative care, rising demand for your services. At the same time, you're getting cuts. You said there's about 3.2 million in expected budget shortfall going into FY27. I guess the question is, at this point, do you have a sense of scale of what you would be thinking if that stays the situation, kind of the scale of requests you would be looking for from state government, local government, other partners?
I can't say it on the state government side. So VDH really manages the budget request to the General Assembly, and then they get a pot of money, and then that money comes down to the local health districts, and then we sort of divvy that up between our localities based on proportion. I think what we did last year, we submitted a request that included a small amount for a community health worker supervisor, knowing that in 2 years that funding would be gone. We didn't anticipate that it would be gone in 6 months, but fortunately, all of our localities contributed money proportionally to fund that position, and our intent was to slowly do that over time. I think that's probably a conversation with each locality to say, what is a reasonable expectation that we could submit a request for in a given year to help stabilize the funding for those positions. I think all localities are probably facing similar or asking themselves similar questions. What is the economy going to look like? What federal funding do we receive? How does that impact other things? So, we've made requests in the last 3 years of anywhere between 6 and 14% to localities, and we've received between 6 and 14%. I would expect similar things to try to stabilize our grant-funded positions. And if the state decides they want to give staff a 3% raise, we also have to figure that in as well. So I don't have a great answer for that, other than to say I think it's a conversation between myself, local governments, to really figure out what's reasonable in our budget request for the next fiscal year and the years to come.
At this point, heading into the next General Assembly session in the new year, is your sense that there is momentum and conversation at the General Assembly level in terms of increasing state funding to try to fill the gap? Is that something that at this point seems to have momentum, or has reached the attention of gubernatorial campaigns? Kind of, what is your sense of where that stands?
VDH has put together a couple of additional funding requests for more positions, more stabilized and regular funding from the General Assembly. I don't know what the momentum is among the elected officials at this point. I think because those are trickling up their way to the General Assembly, it's going to be some time before we have a sense of what may or may not get approved. I think VDH had submitted some funding requests 2 years ago for community health workers focused on maternal child health, and that was passed. So short-term history, there is some momentum building, but in terms of like all of the things that the federal government provides to states, I'm not sure where VDH ranks in their priorities in relation to other government agencies.
Thank you.
Welcome.
So Ryan, thank you for information. I have kind of a question. It's if you had like a special magic wand, not me, not wand, and you could address like any of the issues in the community health assessment, what would you like say? That's what I want to address or get, make it go away.
Social drivers of health, social determinants of health. That's the base for everything for people. Quality housing, access to food. It's the true root cause of what we're trying to solve and the upstream problems that exist that have upstream solutions. And I think if we can focus on those barriers to healthy food, housing, transportation, the things that people need just to improve their overall health, I would love to have a greater ability to work on that. For us, obviously we're a community health strategist led by Jen in this process. We'd love to have more community health workers that really connect individuals to the services that they need, that really do focus in a lot of ways on the social determinants of health.
Thank you. I threw you a little curveball there. That's good.
Thank you. Appreciate
Thank you
it.
so much.
Yep.
Appreciate all the work that y'all do.
Thank you.
Thank you. John, with Child Health Partnership?
Good afternoon. I really appreciate the chance to talk and share with all of you this afternoon as well, and appreciate your time, and particularly following our good partners at the Health District and the Free Clinic. So I'm John Nafziger. I'm Executive Director with Child Health Partnership. Just celebrated my 10th anniversary with the organization, which is hard to believe. I want to introduce, we have one of our board members, Greg Winston, who's our treasurer, is here as well, and I'm sure Greg would be happy to help answer questions later if you have questions for him. I know some of you are very familiar with Child Health Partnership. Some of you maybe less so I'm going to try to quickly give some background to the program. And as you see, our mission focuses on at-home support for children and parents to promote health and well-being of families facing challenges in our community. And I think the broad messages I would share today is that I think our program is in a pretty good, relatively strong place. And the families we work with are facing really intense, greater challenges than what we've seen in certainly in my 10 years with the program. But we work with women and with families to build trusting relationships, to remove barriers, and as has been talked about, really kind of on the ground, individually working with families to address social determinants of health. So I'm going to throw a couple of statistics or ideas at you. One is this one, that children have about 2,000 days between when they're born and when they get to kindergarten, which in some ways is a significant number, and in many ways goes very fast. And those are all days and moments when kids are either getting positive support that's going to prepare them for school and for life, or are missing out on that support. And our program, Child Health Partnership, is a model. We use registered nurses, community health nurses, and trained parent family support specialists. Each family has a team of a nurse and a family support specialist who go out to the home. That is a way to remove barriers to service. Families don't have to worry about childcare. They don't have to worry about transportation. And it's a situation where we can just develop very different, much stronger trusting relationships with families than can normally be developed in a clinic or a more institutional setting. So the pillars of our program in doing that are child and family health, working on parenting skills and child development, and then fostering family self-sufficiency. This is our 35th anniversary, which we're excited about. I think all of you should have an invitation or one in the mail for our celebration on October 19th, and we'll be reaching out to you as well. I wanted to say Child Health Partnership started in 1991 as a local government effort with the program under the Health District and MACA. And that was our how we worked up until 2008, so our first 17 or 18 years, and the second half of our time we've been an independent nonprofit in the city and the county. And in these three kind of pillars of child and family health and parenting, child development, and self-sufficiency, our services then are really individualized to each family, of where they're at, what their goals for their children and their families are, and what they're hoping to, how they're hoping to move that. This is something that you maybe have seen, but it really is a kind of well-established research that the impacts prenatally and in those first few years can be so profound in terms of the trajectory of children's lives. And where we're working with families to provide support, identify and provide needed assistance that really are not interventions. It's before, it's things are to a place where children need what would be considered an intervention, that we're able to identify what supports are needed. So I mentioned the challenges for families in this last year now. All of the families we work with are under-resourced. Of families enrolled in the last year, 65% were food insecure when they came into the program. I wish I could say after a year that none of them were, but it's still a real challenge. Likewise, coming into the program, 30% of families had moved at least twice in the previous year. We can assume that moving once might be a good thing, might not be a good thing. Pretty much 2 or 3 times is kind of universally a problem and shows instability and kind of the needs that we're trying to address to give babies and young kids an environment where they can grow up with the support they need. So our nurses focus on the health side of things, prenatal support. We do depression screenings and a lot of health education and a lot of focus on improved access to medical and dental care. And our family support staff are focused on child development. We work hard to build that parenting bond between the parent and child. We're not kind of going there to do an intervention with the child, but to build that relationship, to build parent confidence. We work closely with Department of Social Services. We have some families that are connected to DSS, some that are not. We have children with complex, significant medical needs, not all of them, but certainly for some families it's helping to navigate a complicated health system to get their kids the help they need. And then one of the other programs that we've been able to add in the last year is kind of peer support parenting groups for new mothers. With an evidence-based model. We've been working in the last year with the Women's Initiative on that. We've run 3 groups for about 40 parents and are planning to continue that into the coming year. Our services are free to families and are completely voluntary. That's one of the things that I say we have a really diverse group of families. You see 225 in the last year, and the one thing they have in common is a desire to improve the lives of their children and work to figure out how they can best do that. And then we both coming into the program and ongoing, we track a lot of data and have a lot of good outcomes in terms of the impact. Almost all of our children have medical homes and are up to date on immunizations. Almost all are current on developmental screenings to see what supports they need for good development. And you'll see further down that list, again, I mentioned that 30% of families had moved twice or more enrolling in the program after a year. That's down to 12%, which is not where we'd like it to be, but a good change. Likewise, for children who needed medical care and didn't get it, after a year in the program, that drops to 3%, and dental drops very significantly as well. So then, finally, a kind of update on where we're at right now. We've had a good year in terms of staff continuity, and which is really important for the work we do, building long-term relationships with families. I mentioned the outcomes that we're really pleased with. We've continued to see, coming out of the pandemic, an increase in the referrals we're getting and enrollments in the program, and I think largely due to a very fortunate staff addition. We've seen a good year in terms of our private fundraising, without knowing what the coming year is gonna hold. In terms of challenges, We have, when I think originally when the program started, this was kind of seen as a, CHIP as a Virginia model was kind of seen as a 50-50 state local match, and we are now just over 20% state funded. And we have made up that gap with private funding, but effectively, we haven't had an increase in our state support since 2017, which effectively is about a 32% inflation, 32% effective cut over that time. So even going into this year, that is a challenge for us. And I think just mention in terms of ongoing pandemic impacts or family stress, it is a very different time than it was 5 years ago. I think for many of us, including the families we work with, of how we feel about being around people at all, much less people coming into our home, that is a kind of a challenge that we still work with, and it is just a difficult time in our society to build new relationships, to engage families and be able to build trust. I think again, compared to what that looked like a number of years ago. For our federal impacts, I put budget second, because the biggest impact we've seen, honestly, we work with a lot of immigrant and refugee families, and it's been and remains a very, very difficult time. Families are under a lot of stress economically, in terms of work, in terms of immigration policies, and in a lot of other areas. So that certainly, I was going to say trickles down. It's more than a trickle, but impacts our frontline staff as well, to going out and working with these families on a regular basis and helping them problem solve and try to figure out how best to move forward. In terms of budget, we are, as it's shown, in terms of direct federal funding, we have one grant, which is through the Virginia Department of Health. At the moment, we have not heard rumblings of that being a problem, so we think that's good for the coming year at least. And we'll see. We are fortunate that a couple of years ago, our state funding was largely federal TANF dollars, and that changed a couple of years ago so that it's all general fund dollars at this point. We still, between local government and state government, we're about 2/3 government funded. And so impacts related to SNAP and Medicaid and other programs, those pressures on budgets are certainly going to be pressures on us as well. Again, thank you. We really appreciate the partnership that we have and have had for 35 years with the city, and happy to answer any questions.
Thank you, John. I'll start with you. Michael, you have any questions or comments?
Sure. So, favorite question, always money. It sounds like you're in relatively stable place in terms of federal funding. Obviously, as you highlighted, increased state funding would be a big priority, and that, along with health district funding, may be important for our legislative agenda and talking with our state representatives about. Beyond that, over the next year or two, are you anticipating any budget gaps caused by an increase of demand that you're expecting, or at this point, do you not know enough to know about the scale of any potential funding gaps?
I don't know what will happen in terms of, we have in the past few months flipped into a small waiting list for services. So what's going to happen in that regard, I don't know. I mean, one of the great challenges of nonprofit budgeting is that providing more services doesn't mean you have more revenue. I think we are looking to manage that. I would still, in terms of my concerns and I think our challenges, I would put budget as second or third and not first, if that's kind of part of the answer. We do, in terms of legislative agenda, we have been working the past 3 or 4 years related to a state funding increase specifically targeted to being able to do a trial and move to, we use a lot of evidence-based tools. We are not, as a Virginia model, we are not currently considered a federal evidence-based program, and therefore there's federal money that we are not eligible for. And a state increase would allow us both to increase numbers and get that study research done to then open those other doors. I mean, that would take a while, but so that's the ask we've had the last couple of years, and it's the ask that we're planning to go back with. I know that there is some support for that. We're the kind of work and program that almost everybody supports. It's a question of whether we're high enough on the agenda to get those dollars.
That's helpful, and I know later on in our meeting, we have a first discussion of our legislative agenda, so timely, but thank you.
That would be a great support to be on that agenda.
Natalie,
Yeah, for the legislative agenda, we get feedback from some different city departments, and then we can add whatever we want, and we talk about it. And I guess this is a question for Sam. Do we get an official legislative request from any of these groups?
No, we have not solicited. They come in at times, I guess, through various conversations, but I'm not aware. I don't think we've had anything come in specifically from any of our community partners.
Okay, so like an official bullet point might be helpful.
Yeah, I would be happy to do that. I think we maybe shared something last year, but pretty late in the process, so I don't know where it fit in, but would be happy to do that.
It would help, and Ryan, I'll add, as well as just let you know that if there's anything specific for any of the associations that you're a part of, if you provide the specific language, then we can make sure that that's available for council to consider.
That's all, thank you.
Brian?
Yeah, no comment. Thank you for your service to the community.
Thank you.
Lloyd?
I have a question that I guess I would like to address to you as well as to the other folks who have already spoken, if we could get comments there too. One of the things that strikes me about the 3 different presentations we had, as well as just generally knowing what else is going on in the community, is that the public health aspect of things is really an ecosystem. And it's got a lot of component parts and a lot of needs that some you may address, some Blue Ridge may address, and so on. Are there needs that nobody is addressing that we should be aware of?
I would say certainly not the ones that are in the top 10 on the list. I mean, I think the work of the MAP, the community, that the health assessment, those have been shifted some, but been pretty steady over. Well, I've been part of that process longer than I want to say, but certainly over the last 10 or 15 years, that mental health, I mean, social determinants of health, much of that comes down to housing, transportation. We haven't mentioned for our families, there is certainly an impact around preschool and childcare access, ability to work. I mean, we are seeing families in the last couple years working more than before. Not that they weren't working before, but
Right.
Folks working second and third jobs that didn't have to do that before. So that's a piece, but and I think you're absolutely right that even when we talk about social determinants of health, those are all employment and income and transportation and healthcare. All of those are so intertwined that for specific families, they play out in different ways. And, you know, I think what we see is, in very broad strokes, the free clinic dealing with a lot of adult healthcare issues that impact those other things. Because likewise, if you have the health issues going on first, then employment and parenting become much more difficult. You know, a lot of systemic work from the health district, and you know what our staff ends up doing on a daily basis is kind of addressing that very immediate, whether it's housing or keeping the electricity on, or food, or transportation issue that we're helping families problem solve and try to get that, you know, what they need to get done today related to social determinants. So happy
I might
to
ask
yield,
Brian or
happy to
Willa.
yield to other thoughts.
One could be the pediatric dental need, and but I think we lowered our dental eligibility age to 14 to help accommodate that, and we'll see. I mean, it's all based on the teeth. So if there's a 12-year-old that has adult teeth, we can see them, and we'll see them for free. And then there's the CDC, and they see children, but Medicaid. And so there is a cost sometimes for those families that go to that clinic. And I know there's the dental task force, which I'm sure you guys are aware of, that's trying to fix that. So that's the only one in regards to health that I've seen, but I think communities or members are working together to try and solve that I've seen at the free clinic.
I'd love to see someone make an attempt at some kind of Venn diagram where it shows all of sort of what we do and where we overlap. I think it was last week I saw a van from Child Health Partnership there bringing a client to the first WIC clinic or their first WIC appointment. So there's certainly a lot of overlap in what we do. Public health, I would say, is a team sport. It's a community sport. Like, we all need to be engaged around that. Willa brings up a good point about pediatric dentistry. There are very few, if any, outside of the CDC that accept Medicaid as part of their private practice for children, and so that's a huge component that I think is missing, not just in the city of Charlottesville, but probably across the district. I don't know if there's any other gaps. I think what I'm thinking a lot about now that we're moving into the community health improvement plan piece, really the action oriented around improving health and outcomes, is momentum and capacity and resources, mostly in the terms of money, but in terms of staffing as well, to carry out the objectives and the initiatives that we're really looking at. A few years ago, we were able to, in partnership with UVA Health and Centera, offer grants to organizations if they were going to address certain things. And I think we'd love to be able to do that again. I'm just not sure that the funding is there. And so I'm thinking through some ideas around how could we do that as a health district, how could our local government support that, and want to formulate a little bit more of a plan around that. But to me, that's the critical aspect of what we're trying to accomplish in the next 3 years with that plan. It's the implementation piece. How are we meeting objectives that really try to move the needle, even in small ways? And that's going to require a lot of momentum, a lot of effort, strategically from us as a health district, but certainly from our community partners as well. As they also navigate funding cuts, and they also navigate what that means for private donations, and how can we maintain that momentum? How can we provide each other with support? So I don't know if the gap is in coverage. It might be the gap in funding, the gap in momentum that we really need to sustain once the improvement plan is in place.
Okay, thank you.
Thank you.
If I can, I would just add, I think, with a little more time to think, one is
Put you on the
not
spot there.
one is not new and will not be a surprise, but I haven't heard specifically addressed the racial disparities in healthcare and the impacts of social determinant of health, and that is certainly something that is still with us. For our work, particularly. Maternal health outcomes, I think, in the community are not as amazingly bad as they were 10 years ago, but they're still pretty bad. And I think the other for our work, which is starting to get more, be identified more and get more recognition, is really the prevalence of postpartum depression. and what as the most common pregnancy-related illness, and it can be difficult to deal with, but there are actually some good ways to deal with that. So I think the recognition and the efforts to make sure that we're looking out for that is an important one.
Thank you.
Thank you, John. It's good to see. I previously served on your board, and the missus serves on your board now. It's good to see that y'all still doing great work in the community, and just really to get that strong start. I never heard of that 2,000 days, and it's so important. It ties into the public school system that want the children to come there healthy and ready to learn. So it's all kind of tied in together. Thank you all.
The city and our other local government partners are
Yeah.
really the drivers that make it possible.
Yes.
So thank you.
Thank you, John. Thank you all so much for presenting. Any other questions or comments? Thank you guys so much for the work that you do in the community. Can I get a motion to go into closed session, please?
So moved.
Actually, I have to
Oh,
read it.
a real motion, sorry.
Pursuant to Section 2.2-3712 of the Virginia Code, I move that this city council close this open meeting and convene in a closed session as authorized by the Virginia Freedom of Information Act as follows. 1, pursuant to Virginia Code Section 2.2-3711A3, discussion or consideration of the acquisition of real property for public purpose or of the disposition of publicly held real property where discussion in an open meeting would adversely affect the bargaining position or negotiating strategy of the public body. And 2, pursuant to Virginia Code Section 2.2-3711A1, for consultation with legal counsel pertaining to actual or probable litigation where such consultation or briefing in open meeting would adversely affect the negotiating or litigating posture of the public body.
Second.
Did we, Kena, did you want us to vote on,
Hey.
I've initiated the vote.
okay? Okay, so we'll see everyone back here at 6:30. Thank you.
So much for our public.
Yeah.
Motion passes.